Right. Uh, good evening, everybody. Welcome to this another episode of the Coffee with Clinician series. Today, we'll be discussing about the role of the clinical lab in the management of thyroid disorders. We're very fortunate to have with us Dr. Satyanath Mukhopadhyay, Dr. Nishant Raizada, and Dr. Shushruth Sen. Dr. Shushruth Sen, president of ACCLMP. I'm quite sure that there's hardly any person in this group who doesn't know him. It gives me great pleasure to invite Dr. Satyanath Mukhopadhyay, DM Endocrinology, former professor and head Department of Endocrinology and Metabolism from IPGMER, fellow of the National Academy of the Medical Sciences India, a fellow of the American College of Endocrinology, Royal College of Physicians, West Bengal Association of Science and Technology, a person who has published more than 300 articles and written more than 20 book chapters with a citation index of 54. That's really commendable. Associate editor of Diabetic Medicine and Acta Diabetologica, a very illustrious name. And what was more impressive, when I've had a couple of conversations with him, he talks very clearly, straight to the point, and it really changes the perspective that you look at a condition. It also gives me great pleasure to introduce Dr. Nishant Raizada, Professor and Head, Department of Endocrinology in the UCMS and GTP Hospital, New Delhi. He's done his MBBS, MD, and DM from AIMS, New Delhi. Areas of interest include obesity, sleep, diabetes. He's got major achievements in being awarded the Sridhar Rahman Memorial Award, Dr. MMS Ahuja Book Prize Award, Deputy Executive Editor of the IJEM, Treasurer of the Delhi chapter of the Endocrinology Society of India, with over 440 publications in PubMed's index journals. So, with that, I will start the proceedings. Welcome to all of you. Now, the first thing which a quick comment from the endocrinologists about the kind of the lab reports that we get from the patient from different labs. Do you find it a bit in some bit of variance, and how much is that troubling you? And then we'll ask Dr. Shushruth Sen to comment upon the various pre-analytical factors that can impact these results. So how much is actually this variable or inconsistency in the reports of thyroid profile that you face in clinical practice? Dr. Nishant?
That is actually quite common, sir. Patients get a lab test done and it is abnormal, and they are worried whether it is actually abnormal or the lab has made some error, so they get it done again from a different lab. And sometimes it's only a few days apart, and the reports appear to be quite varied. Thankfully, most conditions, the general direction is correct, in the sense that one lab is giving a value of 9, the second lab gives a value of 6. So all the patient perceives it to be a big difference, but for us, it doesn't make that much of a difference. But of course, when the variance is more, let's say one lab is saying 15, other lab is saying 7, then those scenarios are less common, but that would really create a lot of confusion for us also.
Dr. Shushruth Sen, sir, could you touch upon the various pre-analytical errors that actually impact this thing? Because I am for sure that with all these technology that we have in our lab, analytical errors from the lab is actually insignificant. There'd be a lot of pre-analyticals that would impact the results. So what are the common things that you find or that you'd want to share with us?
Yeah, sure. Pre-analytical factors are not, I have not seen much to be affecting this thyroid results, except one part, that is the timing of assay. That means at what time you are actually drawing the blood. Because most of the cases, the major parameter of interest whenever you are going to diagnose a thyroid patient to be either a subclinical hypothyroid or over hypothyroid or whatsoever. So it is the TSH is the major parameter of concern. So the TSH has got a gross diurnal variation. So somebody who takes a blood in the morning, because as we know, because of this diurnal variation, TSH secretion is maximum in the morning, and at nadir at particularly around between 4 to 6 p.m. So if we encourage the person to give the blood at any point of time in the day, we might be doing some mistakes, which actually what happens, what I was discussing last day also, that suppose you have done a thyroid testing in the morning, and the sample, the result has come just above the normal range. So there is a clinical suspicion of patient being a subclinical hypothyroidism, and the same patient has got a repeat testing at an 11 evening around 6 to 7 p.m., and the results are coming nearing normal. So what happens actually, it's a common nature of patient or human being that they try to trust the normal results more than the normal results. So sometimes these variations are putting us in very difficulties. So particularly the timing of blood draw is very important. Second thing I would like to ask from the endocrinologist, that this is one factor we actually think that what to actually ask to the patient to take the thyroid hormone. That means if the patient is already taking L-troxin or thyronorm whatsoever, so if the patient is taking thyroxine, should we ask them to continue taking thyroxine in empty stomach and come and give blood, or we can ask them to restrain of taking that and come to give a blood? Because usually TSH doesn't vary much with that dosing, because TSH has got a very long half life. But I have seen T4 to be affected quite a few cases whenever the patient has taken the thyroxine and coming to draw blood after maybe 1 or 2 hours. So there we have seen as isolated rise of T4, which is very difficult to explain to the patient in later on cases. So what is your opinion, sir, Shatinath sir,
So,
for that? What to
so
do?
what I so what I understand from what Shushruth sir is saying is the major thing is TSH. There's the diurnal variation, so there is an issue with that, and one should be aware of the timing. And the second thing that sir was mentioning about is what is the advice to be given to the patient: take the medicine and then give the blood sample, or give the blood sample and then take the medicine, because then it will impact on our results. Sir, could we take a opinion from you?
Well, very briefly, first of all, regarding the problem of ESH in the evening and in the morning, see, Dr. Shushruti is harping upon subclinical hypothyroidism. This may create a problem, but in clinical medicine, we always have a situation called serendipity. A patient is coming, say, 300 kilometers away in the evening, florid hypothyroid or florid thyrotoxic. The diagnosis is 100%, near 100% clinical. Before starting treatment, it's a formality to document the condition and do a TSH. So it hardly matters in such a situation whether this TSH is done in the morning or in the evening. The subclinical hypothyroid situation comes in when you screen relatively asymptomatic individuals for thyroid dysfunction. And this is being increasingly indicated by global societies, particularly in women postmenopausal, that you screen them annually or every 2 years. If somebody has type 2 diabetes, you screen them annually or every 2 years with a TSH. Their TSH remains the only recommended test. And preferably it should be done in the morning. Otherwise, you get a false signal. This can go either way. In the evening, the TSH is low. This creates a problem. But if your clinical suspicion is subclinical hypothyroidism, and the patient has a goiter, there are other subtle features, and that you get a TSH which is borderline high. Dr. Nishant actually has already pointed this out. Hardly matters to us if it is 7 or 9 situation like that. So it doesn't matter really. Otherwise, in all asymptomatic patients for screening, TSH should be the gold standard. Coming to your second question, thyroxine or no thyroxine in a patient who is already on treatment with levothyroxine. Well, this is standard recommendation that the patient does not take thyroxine before giving blood sample on the day of testing, because it vitiates the result of 3T4 and it makes dose adjustment difficult. So no thyroxine. Thank you.
Wonderful. So Dr. Nishant, do you have anything to add up on this?
Not much, sir. There is, I have not really checked this again, but I also recall that there is some kind of duality to the diurnal variation, in that sense that there is some peak in the evening also, late evening also.
Yeah,
and that can create a little bit of trouble, which I observed in one patient, which I think I mentioned earlier also, who was a shift worker. So he was employed in a US based firm, and he was working in the night and he was awake in the working in the night and sleeping in the day. So he gave a sample at the usual time. We told to get a morning sample, but that was supposedly evening for him because he would go to sleep around 9 or 10 o'clock in the morning, and he got a borderline high TSH, and it was not being corroborated by anything else. There was nothing else to suggest that he had a thyroid problem. And then we realized that this could be a diurnal variation kind of issue, and we said that you get the sample at the time when you normally wake up, when you were ready for your job. And he repeated the test, and the results were absolutely normal. So this can also, as sir was mentioning, it can work both ways. The diurnal variation can work both ways. So just one thing I wanted to add.
Oh, wonderful. This is something which we've kind of learned, that when you are looking at a index case diagnosing between hypothyroidism and hyperthyroidism, where the clinical suspicions are very high, then a random sample can help you to make your diagnosis because the values are going to be very high. If you're suspecting or screening for thyroid disorders as a part of a health package, then the morning sample would be a important sample. And by and large, all the samples in a health package is also taken in the morning, so we can take that. Dr. Nishant's point is also a very interesting point, that people who are working in time zones, staying in India but working in foreign time zone, one needs to be aware of that and then appropriately ask for the test. So this is a interesting learning for everyone. So let's keep that in mind. This was definitely an eye opener for me. One more thing what Dr. Satynath told, and which is in black and white and clear, is that we have to clearly tell the patient that the medicine, that the sample is given without taking the thyroid dose. That's what I understand, sir.
Yeah,
Okay,
you're right. Absolutely.
so
Spot on.
this brings us to another question, that many a times we've got patient samples in the routine workup protocol. Somebody is admitted in the ICU, let's say for a heart attack or some other condition, and the whole kitchen sink is thrown. I've seen thyroid profiles coming at 2 o'clock in the night and 10 o'clock in the night, especially your admitted patients. Does the TSH levels and the thyroid profile levels in such patients actually reflect the condition, or is there some stress element which officiates the thyroid profiles at that time? How do you manage it?
You shoot this question to Nishant or me or both.
Both.
Maybe Nishant can start, please.
So, whom you have directed the patient question?
So, Dr. Nishant to start with, sir.
Okay, sir. In the setting of a patient who's in the ICU, it is again the clinical judgment is more important. If you're suspecting either hypothyroidism or hyperthyroidism, which is clinically evident, not subclinical, then of course it would be a confirmatory test. We would just be looking to confirm the value, and in which case it doesn't really matter. If it is over hypothyroidism, like sir mentioned, you take it any time of the day, it is still going to be high only. But apart from that, if you do not suspect thyroid disorder, then ordering a TFT in acutely ill patient, it doesn't really make much sense, because you will get what is known as a CQ thyroid syndrome kind of a picture, and it can be quite a confusing picture. So by and large, if there is no major derangement, what we would do is simply we just wait for the illness to pass over, and then we would do the test again and then interpret this if there is any need to interpret in the first place. So I would say that we should avoid ordering tests more, and we should look at the patient more. If we think that there is a thyroid suspected issue, then we should order. If the patient doesn't seem to have a thyroid disorder clinically, then ordering acutely ill patient ordering a thyroid profile will only confuse us. It will not help any which ways.
I would
Dr. Satynath.
Yeah, very
to-
briefly. Yeah, please. Dr. Susan, please.
Yes.
Go ahead.
So actually, the Dr. Nishant has said about the CQ thyroid syndrome. So that when we actually was studying in our MD, that was a very rare of the rare cases. But practically, when we are releasing report nowadays, it is not a very rare phenomena we find, because of the two things. What I think, that whenever the patient after a long illness or something, as everybody knows, I think for others, I am just explaining a bit, that in during the recovery phase of CQ thyroid syndrome, you will find a slightly bulge of TSH above normal range, and a corresponding T3 and T4 to the lower range, a classical picture of a subclinical hypothyroidism. But usually doctors do not ask for thyroid test during that period. But this is why we are finding it so many, because now you have seen there's a package and battery of tests, and you ask something about 4 or 5 tests after discharge for a certain after time period, and the patient was doing a battery of tests where T3 T4 TSH is also there, and there is a remarkable sign and typical feature of this report is coming where T3 T4 is below normal range and TSH just above normal range, a very classical sign of a subclinical hypothyroidism. So these challenges are coming because of this package of tests or series of
Package
tests.
test, yeah.
So
Yeah, that's
UTA
package tests.
two tests are done for a patient who only asks for a urea creatinine or LFT for just for a follow-up patient doctor has asked for. So these particular things are coming very frequently. So I would say that we were discussing last day also that what about the role of reverse T3 in these cases? Nowadays it is available in India. There are reagents available in India of reverse T3, but usually clinicians do not ask, so we have no option to take it for our lab for testing because the wastage chance is very high. So how is the role of this reverse T3 sir in this scenario? So is it going to be requisition is going to come, or it is for your use or useless, whatever it.
So, if I may respond, first of all,
Yes.
this CK thyroid syndrome is a very, very murky area, and the less we discuss in a practical session like this, the better.
Okay.
So, if we just go by certain rule of thumbs, do not, Dr. Hari, do not prescribe your package testing for critically ill patients.
Absolutely.
ICU, trauma center, no package. That is number one. Number two, sometimes it happens that the junior most staff or the nurse sends the sample and it includes the TFT. In such a situation, way out would be to ask the treating physician to refer the case to an endocrinologist if he suspects that the patient might be having CK thyroid. Let the endocrinologist decide. This is, as I said, is a very, very murky area, right? So that following that approach, we can mitigate this issue. Reverse T3 has no role in clinical practice in India outside a research setting. So even if it is available, hardly any role. And Dr. Sushruti told us about TSH being borderline high, which happens 2 to 4 hours following an acute illness, and then your T4 and T3 can be low. Now, suppose the patient has been admitted with a sepsis or a cardiogenic shock. The patient is on a pressure support, which is dopamine, and then the patient develops anuria, and furosemide infusion is added. Your dopamine suppresses TSH, and the furosemide increases T4. So what do? So these nitty-gritties are prerogatives of endocrinologists, rarely critical care physicians. So as I said, any abnormality in TFT, if it is at all done, the case should be referred to an endo. Thank you.
Okay. So here again, we're getting all these pre-analytical errors where drug treatments can also impact the thyroid profile levels. Also, the conditions of the patient, the stress states of the patient, they can also improve. Plus, we've got this euthyroid 6 syndrome. So as sir said, in acute settings, rather than offering a package treatment, package investigation, but that's the trend in all the hospitals. You want to don't miss out on anything. Don't miss out on anything kind of a concept. But yeah, is try to avoid it. If it's not avoidable and you find something abnormal, refer it to an endocrinologist who's got a better hand and understanding of these conditions. But reverse T3 is something which you would say is not really necessary in a vocabulary. That's what I understand, sir.
Yes, not at this point of time.
Apart from its role in euthyroid 6 syndrome, does reverse T3 have any other role anywhere else?
As I said, there are niche areas where this is finding its use, but still at a research level. As far as we are concerned, we do not really need it. I think Dr. Nishan will also agree with me, or You are welcome, Nishant, if you have a different point of view. For managing patients, diagnosing thyroid disorders, we really do not need RT3 at this point of time.
Uh,
Nishant,
I agree, sir. Actually, the secure thyroid syndrome is defined more by the clinical setting than by the TFT report. In the clinical setting, you are taking a brief history, you can easily make a diagnosis. And if you know that the TFT was done immediately after an acute illness or during an acute illness, you, in any case, you would order a repeat TFT after the patient has stabilized for a few months. So there is no rush really to make the correct diagnosis of secure thyroid syndrome, mostly in our practice. And so never felt the need to order RT3, and I was never taught also that RT3 should be something which should be done. So the same as I said.
Okay, so there's
Yeah.
a good. So,
no, sorry to interrupt.
No, sir, most welcome.
Before we proceed further, just one single point. If a TFT has been done inadvertently, say, and you find that both the TSH and 3T4 levels are low, this indicates a grave prognosis in a patient with, say, acute coronary event, acute heart failure, or polytrauma patients.
So once again, I missed that thing. Can you just repeat it again?
If you get a low TSH coupled with a low T4 or 3T4 in a critically ill patient, it indicates a worse prognosis in terms of mortality.
Okay.
So that has been consistently demonstrated across ICU or trauma center-based studies. But again, for this indication, it should not be done, because multiple studies have shown that by replacing T4 or T3 in those patients does not impact on outcome.
Oh, wow.
But that's a serendipity. You get a value, TSH low, 3T4 low. Maybe while discussing the prognosis with patient relatives, you may bring this up, that this is the scenario and the prognosis appears to be quite great. Thank you.
So if I summarize what you're saying, that in acute settings, polytrauma cases and all, thyroid profile definitely is not required. But if by any chance it is done and you find that T3, T4, TSH levels are low, this indicates a relatively bad prognosis. And the sad part of it is, even
Dr.
if you
Arun, sorry,
Yeah.
I can say low T3. Low T3 will happen in nearly 100% of critically ill patients.
Okay, T4.
If it's a combination of low T4 and TSH,
Low T4 and low TSH, it usually indicates a bad prognosis. And the sad part is, even if you try to target treating with thyroid hormones, it doesn't improve the prognosis.
No, it doesn't. Yeah. Thank you.
Okay, so the talk a lot on the subclinical hypothyroidism was running around. So number one is, if you get a patient with a TSH of, let's say, 7 or 8, a 45, 50-year-old patient, slightly obese, you got a TSH of 7, such as T3, FT3, FT4 normal, classically written as a subclinical hypothyroidism. Are you going to treat this patient?
Dr. Nishant Star, I have spoken enough.
So the first thing is, sir, to make a diagnosis of clinical hypothyroidism, you require elevated TSH with normal free T4. And the second thing you require is that this elevation of TSH should persist. So transient elevation in TSH are very common, very well known. And therefore, if you find a report like this, what you need to do, you need to repeat the TSH after a duration of time. Typically, it should be 3 months. But generally, I've found that even if it is an earlier at maybe 1.5 or 2 months also, quite often you find that the TSH has gone back to normal. So if you find the persistent elevation of TSH, then you are confirmed in making a diagnosis of subclinical hypothyroidism. And then subsequently, majority of patients in this scenario would not be eligible for treatment. They have got very fixed number of indications in which subclinical hypothyroidism is treated. The first one is being TSH above 10. Second one is strongly positive anti-TPO antibody, which is typically defined as TPO antibody more than 2 times upper limit of normal. A third scenario could be patient with has a goiter, a diffuse goiter. Sometimes you may not have access to TPO antibody and you find a patient with diffuse goiter. That's also an indication to treat. And a fourth indication would be pregnancy, where there is an entire discussion about what should be the cutoff and what you should do.
We have a separate session coming on that.
Yeah, so that's another a whole plethora of discussion which can we have about pregnancy and subclinical hypothyroidism. Some patients with the dyslipidemia who are at high risk of cardiovascular disease may also qualify for treatment. But again, there is some level of divergence among the clinicians. Some people would treat it for dyslipidemia, others would not treat it. And very, very rarely somebody would treat a patient based upon symptoms. If they have some symptoms and you feel that symptoms might be attributable to hypothyroidism, in which case a trial of therapy can be given. And if the trial benefits the symptoms, then you can continue. But I have very, very rarely given such trials, and whenever I've given the trial, it has always failed. And the literature also supports that there is no real link between subclinical hypothyroidism and the typical, symptoms which are said to be lethargy, tiredness, and fatigue, etc. They don't get better even you normalize the TSH. It has been shown in multiple trials also. So, in my as far as I can remember, these are the indications for treating subclinical hypothyroidism.
Dr. Arun, if I may quickly supplement.
Yeah.
There are two areas where we need a word of caution. One is in children. When we were students, any elevated TSH in children, the standard recommendation was to treat them. That was 30 years ago. Now studies have shown that if you treat subclinical hypothyroidism in children without a strong TP antibody positivity or a goiter, actually this may precipitate ADHD. So
it precipitates ADHD.
ADHD, yes.
Oh my God.
So to are on the side of caution rather than jump into treatment in that group. And the second group is very elderly, say above the age of 70 or so. Do not treat subclinical hypothyroidism unless there is TSH is clearly elevated and there are clinical signs and symptoms of hypothyroidism, because if there are studies which have shown that unless the TSH is elevated to at least 7.9 and you put the patient on thyroxine, that reduces longevity. There are more than one studies.
Okay.
Thank you.
So now I understand that hypothyroidism, subclinical hypothyroidism is not an emergent condition to go gang ho and start treating. Number one. Number two, you still have about 3-4 months to repeat the test, confirm that this person is hypothyroid, and then think about starting a medication. You could supplement it with anti-TPO, and you find that the TSH is raised and the anti-TPO is also raised. Then there's an indication of starting an early treatment. Couples who are planning pregnancy or pregnant ladies, then you would rather start off treatment even with a slightly lower level. A word of caution of starting treatment when a child, maybe it precipitates ADHD, and older people where they found out that treating subclinical hypothyroidism is actually impacting the longevity of the patient. So these are the conditions where one should be a bit chary about jumping into treating the patients, right, sir? Shushru sir, you want to add anything to it?
Absolutely. Yeah.
Shushru sir, anything to add, sir? Okay.
Dr. Susu,
Sir, you're mute. Sir, you're mute. Shushru sir, you're mute.
Oh, yeah.
No.
So I think everything is very clearly explained by Shotinath sir and Dr. Nishant. So
Right.
from the lab end, there is nothing extra inputs we can give on that.
So now we get to the next question, that supposing there was a patient of hypothyroidism, frank hypothyroidism with a TSH, let's say about 60, 70, and you started off with a treatment. What is the time frame that you're expecting the values to normalize? When would you ask for the second sample to see the response to treatment?
Dr. Nishant, please.
So typically, whenever we initiate treatment, the range of duration in which you would want to order a repeat TSH would be between 6 to 12 weeks. So the earliest would be 6 weeks, and it can be as long as 12 weeks. And decision we generally base upon if there is any need to achieve the target faster, in which I would like to do a TSH earlier. For example, somebody is planning pregnancy and you want to hit the TSH target faster, I'll do at a 6 weeks. But typically, apart from that, and it's anywhere between 2 months to 3 months, that is 8 to 12 weeks, is some point of time we will order a TSH. And at this point of time, I would expect, if my dose is correct and the compliance of the patient is also appropriate, then I would expect to see a TSH within the target range at the end of this period.
So even 60 will come back to a normal range of 4, 5 in a matter of 2 to 3 months.
Absolutely, sir.
It depends the dosing. If the dosing is perfect,
Dosing.
if dose matches the gap, basically the TSH rises because there is a gap between the requirement and the production. So if your thyroxine supplementation matches the production, so whatever may be the initial TSH, maybe it will come to a normal range for sure.
Yeah, if I may add very
Sir.
quickly, TSH and free T4, they follow a log linear relationship. It's not a linear relationship. So even a sky high TSH, as the condition suggests, would fall back to normal with an appropriate dose of thyroxine. Another area where we estimate TSH levels more frequently is in neonates and infants because they have more rapid hormone turnover, and you can take decisions by repeating TSH in neonates every 2 weeks initially, and in children, infants, it may be 3 to 4 weeks. Thank you.
Okay, so the statement is usually 2 to 3 months to do the next test, and usually the values come back to normal if the in case the treatment is adequate, and it's not it's going to gradually come down or it's going to abruptly come down. It takes some time before we can see those change results coming to the adequate range. That's number one. Second thing we said was that in pregnant people who are planning for fertility, rather you do it a bit frequently to see whether the response is occurring better or not, so that to improve the chances of fertility. And children also, we're going. You're talking about neonates or children?
Neonates every 2 to 3 weeks initially till the TSH stabilizes, and children, say 3 weeks to a month.
Okay, 2 to 3 weeks in neonates when you're trying to treat congenital hypothyroidism. That would be the kind of frequency in which you're supposed to be treating.
I'd like to add that in
Yeah.
pregnancy, we would do it monthly. If you're titrating the thyroxine dose in pregnancy, let's say we diagnose just before pregnancy or in the pregnancy, then we would do a TSH every 4 weekly. That is slightly early, but again, in pregnancy, you don't want to lose a lot of time.
Okay, got that. So now comes the jigsaw puzzle that we have. What I understand is a classical hypothyroidism, TSH high, FT4 low. You start the treatment, you expect both the values to normalize. Now you could have a condition where the FT4 is low and the TSH is still high. That means the treatment was a bit inadequate. You need to increase the dosage. Now, what happens in conditions where you get some wonky patterns? Patterns like TSH normal, okay, FT3 low, FT4 low, TSH normal, FT4 low. How do you respond to such a condition?
Dr. Nishant, would you like to take that?
Yes, sir, sure. Sir.
Yeah, please.
So this is a scenario where immediately the attention of the endocrinologist will come. As soon as he observes a low T4, he immediately wants to see a parallelly a high TSH.
Correct.
Because if your pituitary is functioning normally, as soon as the T4 levels fall below normal, the pituitary will respond by increasing the secretion of TSH to a clearly high value, unequivocally high value. The failure of the pituitary to achieve a high TSH in the face of a low T4 indicates what is known as central hypothyroidism or secondary hypothyroidism, and we would begin to suspect that there could be something wrong with the pituitary. This is the most usual scenario. The alternative would be some analytical error, because of which there could be some reason in the lab because which the T4 level has come low. This is a problem which I faced in our own lab also. For some reason, our FT4s were coming slightly below normal.
So we're ruling out the analytical errors because that's what we're paid to do. So we rule the analytical errors and then we talk about the clinical part of it.
So, so I'm just saying that that happened, and we immediately got triggered because we thought it is central hypothyroidism. MRIs were ordered, other hormones were ordered, and eventually what we found out was it was just the lab problem. But by and large, a low FT4 with a normal TSH is something ominous for the clinician. He becomes very worried to see such a report.
You
One
have
that I think I support Dr. Nishant to some extent on that. That FT4 as a parameter, I'm not talking about the very good instruments and robust instruments. There are other semi-auto analyzers and other um low throughput analyzers are also there, which does not have a much good CV percentage. So you will generally find that T4 and TSH are more or less pretty robust, whoever the reagent makers. But the FT4 and T3, they are usually the weaker ones, which usually very much of these small labs, they do manipulate these two results to match with the TSH more or less. So getting a T4 abnormal in analytical error, so I think it will be rather you should thank the lab that they are giving at least the right result and they are honest to their results. But it's very true that FT4 CV percentage of FT4 is much higher than of TSH or T4, because as a parameter T4 TSH reagents are much more robust who are available in India compared to FT4. So that part is always remain, that analytical part of FT4 is more or less questionable until and unless you have a very good system like a big hospitals, that the hospital you work or I work. So where I know that it is equally robust, but that the same thing is not
True for
uh,
everyone.
medium or small labs actually.
Okay. Now let's keep play the other combination. You get a T4 TSH slightly high and a T4 also slightly high. Does that kind of pattern ever happen?
So
High.
that is I think my first thing, that a patient has taken thyroxine and came to give blood, although the patient is still having non compensated hypothyroidism, that is not properly compensated with dose, but the dose is taken immediately before taking blood. That is a one possibility. Another, I think Dr. Nishant can say.
So a patient who is diagnosed hypothyroidism and who is on thyroxine, a high TSH with high T4 indicates poor compliance. So he's not been taking thyroxine for most of the time, because of which the TSH has not come down. And he started taking thyroxine only recently, and maybe even taking more than what he should have been taking, maybe popping 2 pills instead of 1. And therefore, you get a high T4 with a TSH which is already high. In people who are not taking thyroxine, one possibility, just based on the report, would be a TSH secreting pituitary adenoma, in which case the pituitary is producing a pituitary tumor is producing TSH. So TSH is slightly high and it is causing the gland to hyperfunction, and you get a high T3 and high T4. And but this case, of course, clinically you'll be able to pick that the patient has presented with thyrotoxicosis. Another scenario, which is again not very common, is what is known as resistance to thyroid hormone, a genetic condition in which, as the name suggests, there is a resistance to thyroid hormone. So higher level of T3 or T4 is required to bring the TSH to the normal range. So sometimes you can have slightly high TSH there and with a high T4.
Okay. So please keep this in mind when you are releasing your thyroid profile reports and you see these patterns. Uh, if the patterns are in trend, very good. If the pattern is slightly deviant, please be free to pick up the phone call and talk to the concerned clinicians. That brings me to Shushruth sir, a question to you. Have you come across situations where you found the thyroid profile results a bit wonky and you had to call the clinicians to figure out what was going wrong? I'm
That
sure
that
that
happened.
was
That happened with one of a very VIP minister patient of us, and he was disgusted with my hospital reports, because initially I have given the person as a hyperthyroid with a frank clinical sign and symptom of being hyperthyroid. Later on, the patient got an euthyroid, and later on, again he tested the sample and got hypothyroid, typical of thyroiditis. But there I had to call the clinician and had to have an explanation of it, that why the patient is having a behaving differently. So obviously the first and foremost thing, the person, because nowadays people are quite well aware with the googling and all this, so that a person does not believe that result of the lab. So the belief towards the lab first goes very wrong. So it needs a proper clinical correlation also, and where obviously the clinician's explanations is very much important to make the person believe that there is a possibility that initially the person was hyperthyroid, and later on patient gradually went deep down to hypothyroid. So that is a condition I have found that where clinicians saved me, otherwise it was very difficult to convince the patient. then my results were perfect.
So that brings us to another interesting question, that all this talk right now is about FT3 and TSH. There are three more parameters which are commonly asked, but I really don't understand where they come in the whole picture of management. FT3, it's bundled up with a thyroid profile, but my talk so far has been just pertaining to FT3 and FT3, FT4 and TSH. So where does FT3 come in picture? Where does the total T3 and total T4 come in picture? What would you recommend? A lab to go with free T3, T4, to go with total T3, T4, or go with total T3 and free T4, that combination? What do you suggest?
Let's hear from Dr. Nishant again.
Yeah, thank you, sir. So, what I was taught was that total T4 and total T3 are more robust parameters than free T3 and free T4 because the concentration is much higher. So the lower the concentration, the greater the chances of error. That, of course, the biochemist would know better than me. But because of that reason, at least at AIMS where I did my DM training, the routine thyroid profile that is ordered is total T4, total T3 and TSH, not free T3 and free T4. Free T3, free T4 were reserved for conditions in which the clinician would suspect that the total T4 may not be reflecting the true picture. So there are conditions in which the thyroid binding globulin, the TBG, would go up. And because of that, the total T4 and total T3 would look above normal range. So common such conditions would be pregnancy, number one, second and third trimester. Use of oral contraceptive pills. Again, both conditions, the high estrogen would increase the thyroid binding globulin. Then you can have chronic active hepatitis, and there are several other conditions in which you would think that the total the TBG would have gone up and the total T4 would have gone up. In such a scenario, when you are finding a discordance between the TSH and the T4, you would order a free T4. But outside of AIMS, I've found that most private hospitals, most labs, they tend to favor free T4 and free T3 for reasons not very clear to me. And in actual practice, we see free T3, free T4 coming to us more often than total T4 and total T3.
Well, sir, I'm going just a bit off the track, but these trends are making things very difficult. So hardly people now ask for T3, T4, TSH. They ask for FT4, FT3, and TSH. I don't know what is the reason, but it's a trend. Like you will always find that whenever you ask for a lipid profile, they ask for a direct LDL. Although I don't find any logic of doing a direct LDL in every patient. So that is a trend that I don't know from where the trend has started, but this is a trend that people nowadays ask for FT4, FT3, and TSH instead of T3, T4, TSH.
If I may comment here,
Yes, sir.
this trend is not seen in academic institutes like UCMS or IPJLR or AIMS or any teaching institute for that matter. In fact, since TSH assay became more robust, more sensitive. See, I've been speaking from my nearly 40 years of experience. So in the initial TSH, which we used to perform at the institute, those RIAs, they used to differentiate between TSH levels of, say, 0 to 5, then 5 to 20, then 20 to 50 and beyond. Like that. Used to give the report as more than 50. Those old RIAs. What has changed dramatically over the years is the sensitivity of the TSH assay.
Absolutely.
And now it puts us in a position where we can actually differentiate between a value of, say, less than 0.1 TSH, which would be highly consistent with thyrotoxicosis, versus, say, value between 0.01 and 0.1. So we are able to distinguish that, and that has reduced the indication for doing T3. And in my institute, I have shared this with Dr. Arun during our discussion, that since the TSH chemiluminations came into use, we virtually stopped doing T3. Even if the requests used to come, T3, T4, TSH from all other departments, and that was a substantial savings on our burden. See, we're spending more time, more money, T3 assay is more demanding, labor intensive. So cut down to 25% of the total T3 indication. And we have year on year data. I presented that in one of our ACCON meetings long back. So the need for T3 has gone down. It's very, very specific now. Thank you.
Yeah,
Can
I
I add?
agree with sir. We have also stopped doing T3 routinely for many years now, or 3 or 4 years, because there was no use to do T3 in the usual settings. Only in the setting of thyrotoxicosis, there are when you want to look at the T3, but those will be very small percentage of the entire number of thyroid profiles that would be ordered. A routine thyroid profile, there is nothing to be gained by looking at a T3 value.
In thyroiditis, FT3, FT4 ratio, does that help anywhere?
Yeah, that is an area where clinical suspicion would be that of thyrotoxicosis, and in those scenarios, T3 can give useful information. So that is one of the laboratory cues that we use. Typically, the diagnosis, the differentiation between thyroiditis and hyperthyroidism is critical. As Dr. Sushrat Sen sir was pointing out earlier, he had a patient who initially was having thyroiditis and he thought that he was having hyperthyroidism, and then later on the report came normal. Patient was worried that what has happened to me. So this distinction is very important because clinically we have to differentiate between thyrotoxicosis and hyperthyroidism. Thyrotoxicosis is the condition in which you have elevated circulating free T3, T4 levels in your blood, and that will cause some symptoms and signs. That is thyrotoxicosis. Thyrotoxicosis can be because of hyperthyroidism, in the sense in which the gland has become hyperfunctional. It could be also because of other reasons. Number one of which is, of course, thyroiditis, in which the entire reserve of thyroid hormone that is stored in the thyroid gland leaks into the circulation because of inflammation of any reason. So these two scenarios have completely different treatments, because in the setting of thyroiditis, the thyrotoxic phase would be self-limiting. It'll go away after a few weeks, and then the patient may become hypothyroid or may become euthyroid depending upon the degree of damage. Whereas if you're talking hyperthyroidism, then you need to start the antithyroid drugs, and you then look at definitive therapies if as required, depending upon the cause, whether it is Graves or toxic MNG or toxic adenoma. Whereas in the setting of thyroiditis, you would definitely not be using antithyroid drugs. It would be counterproductive. It will precipitate hypothyroidism down the line. So the differentiation between these two disorders starts at the clinical level. Clinically, you want to know how long-standing the disease is. If the patient has been having thyrotoxic symptoms for, let's say, 6 months or a longer period, then it would not be thyroiditis in any case. That has to be hyperthyroidism. But if the history is short, maybe 1 month, 2 month kind of history, that is a place where both the thyroiditis as well as the hyperthyroidism become a differential. Then you would want to know what is the onset of symptoms. If the onset was sudden, was it preceded by some viral infection, some throat, some common cold or something? Is it accompanied by any neck pain or tenderness? So these are features
Yes.
which support thyroiditis. On the contrary, if the onset would be sudden, because there is a sudden release of the hormone from the gland, so the patient would be able to tell that I was completely well by 1 or 2 days back, and suddenly I began to feel these things. On the contrary, a patient of hyperthyroidism would say that I've been having these symptoms for a few weeks or months. I can't really tell when it began. So that's a more gradual kind of onset that occurs in hyperthyroidism. The next would be, you would want to look at the gland. If the gland is enlarged, and then that favors more towards hyperthyroidism, although it can be there in thyroiditis also some cases. And then, of course, then you would also look at any tenderness in the gland. Tenderness would favor thyroiditis again. And after that, by that time, by and large, you would have made up your mind that this likely is going to be hyperthyroidism or it is thyroiditis. And then you would look at the lab report. So in the setting of thyroiditis, the release of stored hormone occurs, and the store is predominantly T4. So if you see a T4 which is clearly high, a T3 which is normal or maybe slightly high, and a low TSH, then you are thinking more in terms of thyroiditis. On the contrary, if you see an elevation which is more dominantly in the T3 rather than the T4, then you are probably thinking about hyperthyroidism. So as we know that the T3 is a more economical molecule to produce for the hyperactive gland, because it needs only 3 iodine atoms. So in hyperthyroidism, the predominant secretion is that of T3. So a T3 to T4 ratio was being used in the past. I think probably in Dr. Satyanath's time, it was one of the important markers. But in the recent textbook, they don't mention the T3 T4 ratio as such with that much importance. They rely on other factors more. But still, I have observed it consistently that the degree of elevation, the number of times the upper limit of normal the T3 would be, it will be much lesser for the T4 in most patients with hyperthyroidism. So,
So, yeah, one more question I'd add up for that. So, is this any role of this looking at the peripheral conversions, whether the peripheral conversion is high or not? So, when T3 is getting raised, so your treatment, does your treatment differ with that
uh,
scenario?
No, sir. I am not sure how we would be able to tell peripheral conversion, what percentage of that is coming from peripheral conversion. But the treatment doesn't depend that much upon the T3 or T4. The main thing is to make it, whether it is hyperthyroidism or thyroiditis, the degree of elevation of T3 or T4 doesn't really change the treatment much. We, by and large, give the same treatment, irrespective of whether the T3 is slightly high or very high. Sometimes, even by this point of time, we're not very sure if these results are also not very conclusive. Then we would look at imaging to give us an answer. You can do an ultrasound, and if the vascularity of the gland is become very high, then that clearly supports hyperthyroidism, whereas a low vascularity would support thyroiditis. And the final judge of this, if you really want a final answer, then you would probably like to do a thyroid scan, maybe ideally with iodine, but that is less often available in the private lab. So maybe a technetium scan. So a normal or increased uptake would signal hyperthyroidism, and absence of uptake is very typical of thyroiditis. But it has to be done in the thyrotoxic phase when the TSH is suppressed. So that is important.
Just 2 quick points, if I may add. Do we have the time?
Yes, we have the time. We have the time.
So the one situation, which is a rare situation where T3 in addition to T4 is helpful, is accidental or suicidal intake of loads of thyroxine. In such a situation, and again, morning, evening doesn't matter. Somebody has ingested 50 tablets, usually children. Nowadays, this is becoming rarer because most companies are providing child-proofing on the cap. So children cannot open it. But then with suicidal intent, 40, 50, 30 tablets are taken. Usually nothing happens because such attempts are usually taken by young, apparently healthy individuals. But to prognosticate, if you see, the body has its own mechanism, teleologically speaking, to reduce the conversion of those excess thyroxine into T3. So if the T3 level is normal, it's not going up, you can rest assured and know that the T4 will be metabolized and nothing much is going to happen. That's number one. Number two, when you are treating hyperthyroidism, there is a subset of patients where your T4 is normal, TSH as expected is still suppressed, T3 continues to remain high. It's a subset of patients. We call that T3 toxicosis. Just to keep that in mind, that this TSH T3 is high, and so maybe that explains why the TSH is remaining suppressed. So and you take account of that and adjust your treatment accordingly. And maybe again, this is theoretical. Propyl thiouracil, which in therapeutic doses reduces the conversion T4 to T3. So maybe it can be an indication, but it's not a standard indication, which Dr. Nishant has already pointed out.
Intending the question.
Yeah, so but PTU is such a rare situation. Maybe you can consider for a short period of time. Thank you.
Okay. Now I just have the discussion is going long and long, but we need to cut it short. Two important points which I wanted to discuss and highlight for the audience also. Supposing a patient comes with a low T3 and a high FT3, right? We're talking about hyperthyroidism. Any further lines of investigations, or this too is good enough and we can start off the treatment?
Low T3 and high FT3?
No, low TSH and a high FT3. So that's all written that it's a patient is anxious and tremors are there. So we know that this is hypothyroidism. Any more investigations required, or just start treating the patient and titrate it with the symptoms?
For most cases, we would do based upon the examination history. Examination would make a diagnosis.
Right.
If the patient has got a diffuse goiter, and these are the reports, then by and large, the diagnosis would be Graves' disease. If you feel that the gland is nodular, especially if you feel multiple nodules, and if the patient is a relatively older person and who has had a long history of goiter, you might be dealing with toxic multinodular goiter. In which case you like to do an ultrasound also, and maybe also do a thyroid scan to see which of the nodules are hyperactive. Or sometimes the patient got a single nodule, and you might think that this could be toxic adenoma. So the treatment of choice in these conditions would differ slightly, and therefore you might want to do a thyroid scan and ultrasound additionally. But for most patients, the majority of the patients with hyperthyroidism or Graves' disease, in which case the diagnosis can actually be made clinically, and there is really no need to order more investigations apart from a thyroid profile and a clinical examination.
long-acting thyroid antibodies and all theoretical discussion, or it doesn't have a practical relevance?
Uh, if you look at the guidelines from Western countries, they would say that to make a diagnosis of Graves' disease, you need to do anti-TSH receptor antibody and document the level. But there is it's an additional step to be done. It doesn't really change things much. Diagnosis can be made clinically. It has been made clinically over the decades, and I still don't think that we need to rely on the TSH receptor antibody to make a diagnosis. The antibody can sometimes confuse you also. So I would not really depend. We do not order TSH receptor antibody for every patient. Only special scenarios when there is some reason to order, we'll go for that. But routinely, we do not do.
Okay. Then we have a few questions from the audience, which I just want to share up with you. A near normal FT3, FT4 with TSH greater than 100. We've got these pictures a couple of times. So how do you actually interpret these? Do you call them subclinical hypothyroidism or what? At 100 TSH, greater than 100.
As sir was mentioning, the relationship is log linear. So very small decrement in T3, T4 near the normal end of the lower end of the normal range can express a very large rise in the TSH. So slightly low T3, T4 is not slightly low, it is low. If once it has gone below the lower limit of normal, it is low. It is slightly low, severely low. That doesn't really make much of a difference to the TSH level. TSH level will shoot up regardless. So if it is below upper limit of the lower limit of normal and TSH is 100, I am not worried. It is routine hypothyroidism for me.
Okay, then we've also found that people with
Lower range,
sir.
even if it is to the absolute lower range of the normalcy, that is also a frank hypothyroidism because the TSH has overworked that shoot up, and that is because of that overwork. Still, T3T4 is hovering around the lower range. So anyhow, the diagnosis doesn't differ much. The diagnosis was mostly on TSH.
It was noticed that people with hypothyroidism are more prone to developing hyponatremia. Is there any real association to that?
That is actually very well known, sir. Hypothyroidism, clinical overt hypothyroidism with low T4, it's an important cause of hyponatremia. In fact, when we see any patient with hyponatremia, the first two questions we want to ask are: is the thyroid function normal? Is the renal function normal? In fact, the most common cause of hyponatremia is SIADH, and to make a diagnosis of SIADH, you need to exclude hypothyroidism and hypoadilism both.
Okay. And then a small talk on neonatal or congenital hypothyroidism. So when do you suspect clinically, number one? When is the investigation to be done? And the debate between, do you do it cord blood or do you do it with the 2 days? Because immediately after birth, taking it, there is some transfer of hormones from the mother to the child. So the results are not right. They say do it after 2 days. So what is your recommendation?
Let's start with Dr. Nishan. Nishan, please.
Yes, sir. Neonatal hypothyroidism is quite a devastating disorder if not treated, diagnosed and treated in time. And it is even more saddening because it is very easily treatable. If you make a diagnosis, you can treat. But if you delay the treatment, if you can't make the diagnosis in time, then the child will have permanent consequences in terms of the neurological deficits. Therefore, most of the developed countries would have well-established screening protocols in place. Unfortunately, in India, there is no uniformly followed screening program. The good thing that is happening is that the large number of deliveries now are occurring in hospital rather than happening at home. In which case, if they are happening at home, there is no way of screening at all. But even in hospitals, the hospitals are few and far between. The number of deliveries are really sky high, and there is a pressure on the labor room to discharge the patients as early as possible. So most normal deliveries in which there is no complication to the mother, they would be discharged by day 1 or day 2. So the usual recommendation, which is otherwise correct, that you should do ideally at second or third day, 48 or 72 hours. By that time, the TSH levels begin to settle a lot, relatively more as compared to right at birth, and they give you a better idea about the hypothyroid function. But the thing is that a lot of children would be discharged already by the time 72 hours post birth has has happened. And even if you take a sample, they would be discharged, and it is difficult to trace them because we don't have their contact details, everything available with us. So even if we take a sample at 72 hours, the report will come at 96 hours or whatever, and you know then it is probably hypothyroidism, but you can't find the child. So therefore, I am of the opinion, at least, that we should try to screen whenever we have got the chance. So although cord blood has got limitations, would be in favor of doing a cord blood testing, so that we may miss a small percentage, some percentage of patient we might miss. But I think the most severe forms of hypothyroidism would be picked up even in the cord blood. And then by the day 2 or day 3, by the time they're being discharged, we'll get hold of them that, okay, you probably have hypothyroidism, we need to do more testing, and we can alert the parents. So because of this limitation, at least in our setting, I would be in favor of cord blood.
Sir, how much time do we have between making the diagnosis and the treatment? And what is your cutoff levels where you say, okay, now this is where we're going to start the treatment?
Yeah, as Dr. Nishant said, so high TSH in the cord blood to make a diagnosis of neonatal hypothyroidism, above 25 or even better above 30. So that is clear cut. And you need not wait, start treatment. The problem with loss to follow-up of those neonates is that unless you start treatment latest by 14 days from birth, there can be significant onset of significant neurological problem, brain damage. So that's the key. You have a window of 14 days. So borderline elevation of TSH, say between less than 20, you keep it as normal cord blood. So between 20 and 30, you take a stock of those patients, note down their phone numbers, ask them to come back in a week, repeat the blood test, and take a call. In centers like say UCMS or our center, we have chemi in place. We have been doing the test daily. Take a blood sample, and within an hour the results are ready. So just waiting in the OPD and you take a call. So no time is wasted. So that is very important. And another thing if I may add, say in developed countries, we have data from Netherlands. They add a T4 to TSH for neonatal screening.
Okay.
And then if you do it in a cord blood, by combining the two values, T4 and TSH, you can make a better assessment and take your decision. Thank you.
Particular borderline cases.
So what I'm beginning to understand is that ideally we should be asking for cord blood because that's always available when we are doing, just we have to train ourselves to be focused and sincere about collecting the sample. Number one, cord blood samples can get processed by immediately. So by the next day morning, you already have the results of the TSH to make your opinion. Otherwise, day 2 also is a good sample to have a look at it. You have a cutoff decision of beyond 30, you have to treat. Below 20, you're not treating, you're weight watching. 20 to 25 may be repeated within 1 week and see where the trend goes. And so generally it's a window of about 14 days before which the treatment has to be initiated. Once a child has been put on TSH, that's for life, or is there any challenge to see whether the thyroid gland is picking up? Is something like that on, or it's a treatment for life?
Yes, Dr. Nishant.
So after initially the thrust would be to start the therapy as early as possible, and subsequently you would like to make a full diagnosis that what is the cause of the hypothyroidism. Is it agenesis of the gland? Is the dysharmonogenesis? So tests would be done once the child is a bit older, and you can make the diagnosis based upon that. So based upon the diagnosis, I would not suggest that we should stop and see before the child has completed his entire growth period. Once the entire growth is over, and if you think that there is a possibility that there could be some recovery, in the sense that probably you think that it was not properly diagnosed, or it was a milder form of hypothyroidism, and probably the thyroid gland is still there in the normal position, you might try to withdraw the drug and you wait for a couple of months and look at the TSH. If the TSH goes up back high, then you mean that it of course means lifelong therapy is required. But if you have a child who's got thyroidogenesis, there is no thyroid gland palpable in the first place, then you of course know that there is no point of doing that. So based upon the diagnosis, in some cases you might want to do this, but it will not happen before the child has completed the adolescence, basically cross adolescence.
That's 14, 15 years or 20?
Something around 16, 17, 18 years maybe roughly.
Right. One last question, because there's a huge lot of questions coming over there. I'll talk to you separately about these questions that we'll fill it up. One last question is thyroid profiles and obesity. How do you interpret the results?
So it is now well known that obese people are likely to have slightly higher TSH as compared to people who are not obese. It is mediated by the effect of several adipokines on the hypothalamus, which increase the TRH levels, which in turn increase the TSH levels. So this is supposed to be an adjustment by the body to the excess body weight. It is the result of the obesity, not the cause of obesity, which is a common misconception among a lot of people. They get a slightly high TSH and they think that probably the thyroid is causing the obesity. And in fact, unfortunately, a lot of physicians also do not know these things, and they also believe that probably this is the reason. And they even start treating these people, and quite often it actually causes more weight gain than causing any weight loss. So in these patients, again, the treatment part is the same. If obesity is there, we would have a cause for the slightly high TSH. We would still do anti-T2 antibody and look at other things, but we would not offer them any therapy in terms of thyroxine. We would, of course, ask them to lose weight. If they lose weight, there are good chances that the TSH level elevation may settle down.
Now, this TSH, we are talking about 7, 8, or we are talking about 15, 20?
No. It definitely less than 10. I would know. I never seen. Rarely seen more than 10.
Okay, then that's the important take-home message, that if a person is obese and the TSH is between less than 10, then it's probably not a hypothyroidism, and it is more because related to the leptin axis and all that. But if it's about 10, then that is definitely a hypothyroid case which needs to be supplemented. Right, sir. Thank you. Thank you very much. I really appreciate this long conversation and a very active and enlightening kind of a conversation. I thought I'd been done with it in the last two discussions with all of you, and I thought I knew, but today's discussion also threw a lot of new and interesting aspects. Thank you very much for the discussion, and till we meet again, sir. Thank you.
Thank you very much.
Thank you. Thank you, everybody.
It's really a pleasure interacting. Good night.
Good night. Have a great evening.
Good night. Thank you, sir.